Welcome. In our last meeting, we were talking about obstructive airway conditions. We outlined a number of airway conditions that are obstructive, and we said amongst the conditions that affect the airways are those that obstruct the flow of air, which we talked about in obstructive conditions, and there are those that restrict the flow of air, that restrict the breathing processes. Okay. So we talked about the obstructive ones, and now today we are talking about the restrictive airway conditions. Okay. So amongst them, the commonest being pneumonia. Okay. The commonest being pneumonia. So pneumonia in general refers to infection. Actually, pneumonia in this category is like the prototype of the diseases that are in here. So understanding pneumonia gives you an understanding of actually most of the conditions that fall under restrictive conditions, because most of what goes through in pneumonia is what also happens in other smaller conditions. So pneumonia is a general term which refers to an infection within the lung tissue. It is caused by a bacterial or viral infection that becomes purulent and filling the alveoli, which may become solid at the end of the day. So generally, pneumonia would arise due to inflammation of the lung tissue. Okay. Pneumonias can be classified by either their infective nature or the causative organism. So if we classify it by the causative organism, we would say pneumonia or by an infective organism, the organism that has caused the infection. We would say pneumonia can be bacterial pneumonia, okay? Which is when pneumonia causing bacteria masses and multiplies in the lungs. It can also be caused by fungi. It can also be caused by mycobacteria, as well as a viral pneumonia, such as a COVID. Okay, so pneumonia, simply put, is due to inflammation of the lung, or the condition that is caused by inflammation of the lung, regardless of the cause, is what is referred to as a pneumonia. Okay. Or it can be also classified by how it was acquired. Okay. So if we classify it by how it was acquired, we can say there is a community acquired pneumonia. This is the most common form of pneumonia and describes pneumonia that is acquired outside the hospital in the community. It is important for you to describe it like this so that you know exactly where this problem is coming from. Okay. It could be that in a certain community, there is infestation of bacteria, viruses, or fungi that is causing pneumonia. So once you classify pneumonia as such, it gives ideas of where the problem is. You know, prevention is always better than cure, and now we have a robust public health system. Okay, we have a robust public health system, meaning at least these guys who work day and night to see to it that reported virus in the community before it causes a public health hazard, it is dealt with. So it is important that those of you that are working from the hospitals, when you discover this, you classify them. And if it is causing a public health threat, you throw it to the public health department so that they go in the community and try to uh, sort it out from there so that we reduce on the cases that are coming to the hospital. Hospital-acquired pneumonia, okay, can also be there if this type of pneumonia is caused from the hospital, okay? It could be ventilator-associated pneumonia. The person came in without pneumonia, but because of the ventilators and all those things that you put in the hospital or the contamination around the hospital, this person develops pneumonia. It is important that you classify it as such so that people can know where the problem is and preventive measures can be instituted therein. Aspiration pneumonia is commonly caused by inhaling a foreign object. So even aspiration, a person gets choked, the food vomit goes to the airway and gets infected, the lungs become inflamed, it can cause what is known as aspiration pneumonia. The pathological description of pneumonia can either be bronchopneumonia or lobar pneumonia. Okay? And pneumonia also has some stages. It has four stages in which it progresses, namely consolidation, red hepatization, gray hepatization, and resolution. Okay, these are the four stages which are usually could be observed in lobar pneumonia or in bronchopneumonia. Okay, so in consolidation, cellular exudates containing neutrophils, lymphocytes, and fibrin replaces the alveolar air. Okay, where the air is contained, it is replaced by these exudates. Capillaries in the surrounding alveolar walls become congested. The infection spreads to the hilum and the pleura fairly, thereby causing pleurisy, which is one of the conditions again which cause restriction. So see what I was saying, in pneumonia you find a lot of other smaller conditions. Okay, once it starts spreading, going to the pleural membrane, it causes pleurisy, marked by coughing and deep breathing. If it's let to go unabated, it graduates into the second level, which is red hepatization. At this point, the consistency of the lungs resembles that of the liver. Okay, the lungs become hyperemic, and this stage is characterized by the presence of erythrocytes, neutrophils, desquamated epithelial cells, and it becomes reddish like in appearance. Then if goes unabated, it goes to gray hepatization, which is an avascular stage, and the lungs appears gray-brown to yellow because of fibrinopurulent exudates, disintegration of the red blood cells, and the hemosiderin. Then resolution finally comes in. At this stage, is characterized by resorption and restoration of the pulmonary architecture. Large number of macrophages enter into the spaces of the airways and starts to phagocytose the bacteria that has been causing this disease. Therefore, consolidated tissue re-elects and the fluids infiltrate, causes sputum. Then at the end of the day, there will be sputum coming out. And these are the four stages of pneumonia. So when asked to talk about the stages of pneumonia, you will be expected to talk about those. Okay? Tell us about those four stages. Signs and symptoms of pneumonia. There would be pleuritic chest pain due to localized inflammation of pleura and can be seen with any kind of pneumonia, but it is more common in lobar pneumonia, pleuritic pain. We have already talked about where this kind of pain can come about when there is infection that goes on to affect the pleura. Constitutional symptoms of pneumonia because of infection includes fatigue, headache, myalgia, arthralgias can also be seen. Severe pneumonia, including fever, because we're talking about infection, including fever can be there. Severe pneumonia can lead to dyspnea. Okay, so these are things that are going to cause the restriction. In restrictive airways, the function of the lung tissue to expand and recoil is just disturbed. It's impeded, that activity, that characteristic is impeded by other factors such as pain. Okay, just like we have seen in pleuritic chest pain. No one will be able to breathe in to the maximum if they are feeling pain. Okay, this is different from what we talked about in COPD. Chest auscultation will review crackles, rails, bronchials, so breath sounds. You need to know these breath sounds. You need to know how to describe each one of these breath sounds and in which condition each one of them are found. Hypoxia is seen in severe pneumonias which lead to hyperventilation, and this pneumonia can complicate into other conditions since it is just an umbrella term which talks about inflammation. It can still spread and cause other conditions such as pleural effusion, empyema, lung abscess, bacteremia, sepsis, meningitis, septic. So it can go on and on up to causing endocarditis and pericarditis. Treatment depends on the cause. Antibiotic if it is caused by bacterial, antiviral if it is caused by virus, antifungal if it is caused by fungus. Okay, so that is about pneumonia. Then we said pneumonia can complicate into pleurisy. So pleurisy, from what we can see on the picture here, under normal circumstances, the lung is supposed to look like that. But if you look at this line here, pleurisy is simply the situation where the pleural membrane is inflamed, okay, or pleuritis. So when you look here, the normal text is supposed to look like that, but in an inflamed one, it will look like that. So pleurisy, also known as pleuritis, is the inflammation of the pleura, which is the sheet-like layer that covers the lungs. We know about the pleural membrane. We have the parietal pleura and the visceral pleura. So those two, when you are breathing in, from the mechanics of breathing, we learned that those two, they slide on each other, okay? They slide on each other. But due to infection, those can be inflamed. And once they are inflamed, it leads to pain, which worsens when deep breathing and when coughing. So that sharp stabbing pain in the chest area, often in the lower part, will stop this person from wanting to breathe in deeply or from coughing because of that pain. And that is what is causing restriction in breathing. And that is why it is referred to as these conditions are known as restrictive pulmonary conditions. Therefore, deep breathing, sneezing, coughing causes the two layers of the pleura to rub against each other, which makes the pain greater. Okay? It can be somewhat eased when the patient when the patient sleeps on the afflicted side. The presence of additional symptoms depend on the underlying cause. So we've had, it can be caused by a lot of other things. So additional symptoms will follow according to what any other condition is that has complicated it. Fever and chills are common because of the infection that has caused this condition. Fluency is frequently seen in symptoms rather than it's seen as a symptom rather than a disease. Sometimes it is impossible to know the precise cause of pleurisy, but the following conditions can be linked to pleurisy. Amongst them, we have pneumothorax, pneumonia, okay, and a number of other conditions. So it is usually appears as a symptom, meaning there should be a primary condition somewhere which would give pleurisy as a symptom, okay? Risk factors of pleurisy include intestinal inflammation such as Crohn's disease, okay? Pancreatitis, autoimmune diseases such as lupus and the rheumatoid arthritis can result into that. Complications can be very dangerous and consist of conditions such as pleural effusion, okay? Pleural effusion, empyema, sepsis, as well as septic shock. Sepsis is life-threatening when it causes a decrease in blood pressure. So all these are very serious conditions. So that is an overview about pleurisy. We are moving on. Empyema, okay? Empyema is a condition which is characterized by accumulation of infected liquid within the body cavity or by the presence of pus within the pleural space or the body cavity. So when there is pus, which is an infected body fluid, it will cause what is known as empyema. It is usually diagnosed by thoracentesis, where a needle is dipped, a syringe is dipped into the lung tissue and aspirated the fluid, tested, and this seen that this is an infected fluid, or indeed it is pus. Ultrasound and chest X-rays can also help to come up with the diagnosis. Because of infection, fever is the mainstay. Fever, cough, and the pruritic chest pain can also be characterized in empyema. Okay, it is usually treated by usually this kind of infection is bacterial, so it is treated by antibiotics or excision into the pleural space to remove the pus. Okay, it could be surgery, excision, and to remove the pus. Causes of bacterial infection could be pneumonia, trauma, or surgery. So this is where an example of the area where this pus may accumulate within the pleural membrane. It may accumulate there and thereby causing a restriction. There is pain, it causes restriction. Once you breathe in, there is tenderness because of swelling all over this area. And compression in the lung tissue also would result because this has reduced the surface area for re-aeration. So this is what happens in conditions such as empyema. Okay, pleural effusion. A pleural effusion is accumulation of excessive fluid in the pleural space and the space that surrounds each, which is the space that surrounds each line. We already talked about the pleural membranes, which is the parietal and the parietal pleura and the visceral pleura. Under normal conditions, pleural fluid is secreted by parietal uh, parietal pleural capillaries at about 0.6 millimeters per kilogram weight per hour and is cleared by lymphatic absorption, leaving behind about 5 to 15 milliliters of fluid, which helps to maintain a functional vacuum between the parietal and the visceral. So there is a balance here. We can get that there is a balance, production as well as clearance. Okay. Therefore, excess fluid within the pleural space can impair inspiration by upsetting the functional vacuum, and this would cause the accumulation. So when we look at the picture here, we can see some fluid accumulating into this space. So these things just differ in names by the prevailing circumstances and the characteristics and the underlying characteristics. Remember a similar situation when it was accumulation of pus that was accumulated here, it was referred to as empyema. Now it is pleural fluid, it is simply referred to as a pleural effusion. So a number of substances can accumulate in that space, okay? Can accumulate in that space, and the name thereof is given by the type of substance that has accumulated there, okay? And all of them are umbrella, the umbrella term that is used for all of them is pleural effusion. But depending on the fluid that is there, the name also arises. If it is serous fluid that is accumulated there, it is referred to as hydrothorax. If it is blood, hemothorax, pus, pyothorax, or empyema. Okay, cow, it is actually referred to as in chyothorax or very rarely urinothorax. So urine can also find its way in the pleural membrane, but that is for pathologies for another day. Pathological conditions that will be discussed in other other discussions other than this one. So for now, let's just understand that urine, there's a possibility that urine can also accumulate in the pleural space, and it will be referred to as urinothorax. When unspecified term of the unspecified term, the term pleural effusion normally refers to hydrothorax, where there is serous fluid accumulation. So it is kind of broad. A pleural effusion can be compounded by pneumothorax, which is accumulation of air in the pleural space, leading to hydropneumothorax. This also suggests classification by origin. So classification of pleural effusion by origin, these are what suffices: chirothorax, pneumothorax, hydrothorax, hemothorax, and others that we have talked about. Okay, so the pathophysiology of which is that pleural fluid is secreted by the parietal layer, which we have already established, of the pleura and reabsorbed by the lymphatics in the most dependent parts of the parietal pleura, primarily the diaphragmatic and uh, mediastinal regions. Okay. There is also what is referred to as exudative pleural effusion, which is classification by pathology. Okay, exudative pleural effusion occur when the pleura is damaged, e.g. by trauma, infection, or malignancy. And transudative pleural effusions develop when there is either excessive production of pleural fluid or resorption capacity is reduced, such as the Light criteria can be used to differentiate between the two. So this criteria is very important. Let's find time to check through it. Okay, Light criteria. Classification by pathophysiology. Transudative pleural effusion and exudative pleural effusion. Transudative pleural effusion in transudates. Transudates are caused by disturbances of hydrostatic or colloid osmotic pressure. Okay, they have a low protein content in comparison to exudates, and thus appear clearer. The most common causes of transudative pleural effusion is heart failure or cirrhosis, nephrotic syndrome, as well as pulmonary embolism. So this is where there is an imbalance, okay, in the production and the clearance. So these are just what causes it, and the conditions associated with transudative pleural effusion could be congestive heart failure, liver cirrhosis, amongst them. Also, we have obstructive uropathy and end-stage kidney disease can result into this type of effusion, which is transudative pleural effusion. On the other hand, there is what is referred to as exudative pleural effusion. An exudate is any fluid that filters from the circulatory system into lesions or areas of inflammation. It can be pus-like or clear fluid-like. So an exudate is draining from an open space. When an injury occurs, leaving skin exposed, it leaks of the blood vessels, it leaks out of the blood vessels into the nearby tissues. And the tissue is composed of serum fibrin, and that is going to cause an exudate, which may ooze from the clot into the areas of infection. So meaning even in the lungs, when there is injury, when there is inflammation, these exudates will exude from the injury into the spaces around it, which is the pleural space. So in the injury in the lung, it can exude into the pleural space. So these are just examples, pictorial examples of what an exudate will look like. So even from the plant, that stuff we see on a plant is referred to as an exudate, and it also happens in humans. Okay, the most common causes of exudative pleural effusion are bacterial pneumonia, cancer, which causes about 75%, of it. Viral infection. Another common cause is after heart surgery, when incompletely drained blood can lead to an inflammatory response that causes exudative pleural fluid. So this is about pleural effusion. So exudative pleural effusion can be caused by other conditions, including trauma, okay, pancreatitis, rheumatoid pleurisy, okay. Fluid is going to drain from the tissue going into the space that is nearby. And that is about pleural effusion. Moving on, amongst the conditions that fall under the category of restrictive airway diseases are conditions such as Guillain-Barré syndrome, which is a neuromuscular disorder. So you find in this disorder, which is characterized by progressive ascending paralysis, you find that this paralysis starts from the peripheral and it keeps on advancing until it gets to the central region where it affects the respiratory system. Okay, so these conditions are quite severe and they are diverse. The ones that characterized with the ones that are characterized by the neuromuscular, or the ones that are categorized as neuromuscular disorders. So GBS being the common one, it will cause respiration, which is ascending from the peripheral, going centrally until it gets to the respiratory muscles and weakens the respiratory muscles. Breathing will be problematic because of the effects that have arisen from outside the neuromuscular, the effects on the neuromuscular tissues. Okay, so you will be required to read the intervention of physiotherapy on in restrictive lung conditions, including the intervention of physiotherapy in obstructive lung conditions. Read this, understand a tailored physiotherapy intervention in each of the conditions that we have mentioned, we have talked about, both in obstructive and in restrictive. These conditions, understand them and understand the intervention for each one of them. But you are going to find a lot of similar interventions in all of them, because if you have noticed the signs and symptoms that we have talked about in obstructive as well as in restrictive, they are very similar signs and symptoms. So meaning even the intervention will be similar, but your treatment should be tailored to the presentation. So read about that in that line. Thank you so much. Thank you for listening.